Thank you everybody for joining us today for our virtual shadowing session. I'm very honored to welcome to you today, Jonathan Baker. Welcome.
Hi, everyone. Thank you for having me. I'm so excited to be part of this. You guys reached out to me just a couple of months ago, and seeing this in action is so very cool. It's such a diverse group of people. I love that you have the closed captioning for different abled people. So that's really awesome. I love the work you're doing. I am in the middle of sending you a donation, but I have to give a presentation first, and then I'll finish it up after. And I'll post my Instagram about it. So welcome everyone. Thank you for joining me. There's a ton of people in here, which is awesome. My name is Jonathan Baker, and I'm a PA in New York City. I use he pronouns and I have a couple of leadership roles, and we'll talk about that at the end. I work in a really special practice. I've had sort of an interesting course getting there, as I think everyone does. And so I'm excited to share that course with you. So I'm going to talk at the beginning about my path and sort of what my path to PA school and becoming a PA looked like. And then we'll do some more sort of traditional shadowing, looking at some anorectal pathology. And then we'll talk about how that intersects with sexual health, talk about the roles of PAs in clinical research, and then the advocacy piece, including mentorship, publishing, and presenting. So this is me. So I graduated from Duquesne University, which is in Pittsburgh. I saw a whole bunch of Pittsburgh people in the chat. So I graduated in 2009, and I was really lucky. I had a mother who had a nursing degree and introduced me to the PA profession while in high school. And so I had the privilege to commit to a 3+2 program where my first 3 years at Duquesne University was undergrad, and then I would go immediately into 2 years or 7 semesters of graduate school for my master's in PA. So I graduated on a Saturday with my undergrad, and on Monday went back into clinical medicine too the following day. But that meant I was able to obtain my license at the age of 22. My undergraduate degree was in pre-PA, which I know a lot of places don't have, but it was at Duquesne. But I got to do a lot of elective stuff during my undergrad, and my favorite was theater, called the Red Maskers at Duquesne University. And I'm not a great actor, dancer, or singer. Most of my work was backstage, but the opportunity to sort of be on a stage with people and make a fool of myself in front of my friends, it turned out to be a really important opportunity for me when I get into later, when I start presenting medical information and at conferences. I also served as the founding president of the university's Gay Straight Alliance, which was called Lambda. And this was also really important. Duquesne University is a Catholic university, and so navigating the politics of a Gay Straight Alliance at a Catholic university a decade ago was interesting and turns out to be really helpful as I grow into some leadership roles. So I lived and worked in Pittsburgh for 5 years after I graduated. And my first connection was absolute luck. My freshman year roommate was a bartender and served a drink to someone who worked for the University of Pittsburgh. A couple of connections, calls, texts later, I ended up interviewing with Dr. Ross Cranston, who is a renowned researcher and pioneer of gay men's health. And sat down, and he had my resume in front of him, and he said, "We have a shared interest in anal dysplasia." And it was love at first sight. I knew this was the position for me. I completed my master's thesis on HPV-related disease of the anus. And so this is where I ended up. I met my partner in Pittsburgh, and we moved to New York City about 6 years ago, where I found a position in the similar field, and that was through connections as well. We got engaged 3 years ago, and our plan for a destination wedding is currently on hold due to the pandemic. So now I'm at Laser Surgery Care, which is a colorectal surgery practice in a notoriously gay neighborhood called Chelsea in Manhattan in New York City. I work with 2 surgeons. Dr. Joseph Trelizzi is in the middle, the tall guy, and the other is Dr. Stephen Goldstone, who's also a pioneer in gay men's health research. He was the first author on the New England Journal of Medicine article, which led to the FDA approval of Gardasil for men, the HPV vaccine for men, which was a really big deal about a decade ago. and is most well known for his book, The Ins and Outs of Gay Sex. So let's get into the shadowing piece of this. So we'll begin with a clinical case. So a 28-year-old develops anal pain and bleeding. Bowel movements are increasingly painful and bright red blood is seen on the toilet on the toilet paper and the toilet bowl following bowel movements. The patient tried preparation H, which burned. What should this patient do? So this patient should probably be seen. However, this patient's ID says that their name is Mark, but they're presenting under the name Jacqueline. This is a male to female transgender individual. So their ID doesn't match, their insurance card doesn't match. They're really worried. Is their provider going to call them he or she? Am I going to misgender them? Will they be judged for engaging in anal sex, which is really relevant to this patient's complaint and symptoms? Will they be turned away? Is that even legal? And the worst of these, will I be hurt or abused by the provider or staff? So Jacqueline is not unlike most people in my community. 56% of LGBTQ individuals report healthcare discrimination. 10% of lesbian, gay, and bisexual have been refused care, and 30% of transgender and non-binary have been refused care. And after experiencing healthcare discrimination, patients are 3 times more likely to defer care the next year. And if that's compounded by people of color who are LGBTQ, they're an additional 2 times more likely to skip out on care. And that might be for things like blood pressure or heart disease, diabetes that are really, really important. So Jacqueline comes to the office and she is very pleased to see my rainbow pin on my coat, my pronouns on my jacket, and feels immediately comforted by these measures. So let's start looking at some of the things that might be causing Jacqueline's symptoms. So this is the perfect anus. So this is what a butt looks like, very zoomed in. My presentation is going to be very graphic. So if this is too much for you, my apologies, but bear with me. So this is all zoomed in pictures of the anus. The anal verge is the opening at the outside. Posteriorly is the tailbone or the coccyx. Anteriorly is the perineum, or the skin between the anus and the genitals. So the pictures will either be this orientation or turned to the side. So a really common cause of rectal pain and bleeding is a fissure. And this is a tear in the skin around the anus. And the textbook definition is that the intensity of the pain is out of proportion to the size of the lesion. So this is really zoomed in. This is about 1 centimeter long. And the patient would describe this as feeling like they're being stabbed when they go to the bathroom. Another really common cause for anal pain and bleeding is overwiping dermatitis. And this is probably one of the most common things that we see. People like to be clean. They like to have clean butts. And so people often end up wiping like crazy. And if they wipe too much, they can really damage the skin. It can callus, it can scar, and it can start to bleed. Skin tags are another common anorectal pathology. And these are just extra skin around the anus. You can get skin tags anywhere you have friction. So they're common in places like the armpit or the groin or the neck. And so you imagine there's a lot of friction between the cheeks. These do not require any treatment, and they often get mistaken for hemorrhoids or warts. An anal abscess is probably one of the most serious things that we see in our office. And this is an accumulation of bacteria and pus under the skin. So unlike a lot of other places in the body, when you get an infection, this sort of walls off and builds this pocket. And people tend to have really severe pain with it. This has to be treated surgically and often emergently. And sometimes we use antibiotics depending on what the bacteria is. External hemorrhoids. Hemorrhoids are probably one of the most common things that people think of with anorectal pathology. So we have a bunch of blood vessels that surround the anus and rectum, and those can become dilated or filled with blood and start to cause issues. This is what they look like externally. You see the bulging skin, and you can see like some red or bluish tone underneath it. That's the blood that's pulling in those blood vessels, and this can be itchy and painful. This is looking through a scope, looking at internal hemorrhoids. So these are bright red, you see a lot of blood accumulating, and these sometimes require surgery as well. Gonorrhea and chlamydia. So remember, our patient was engaging in anal sex, so they're at risk for sexually transmitted infections, including gonorrhea and chlamydia of the anus and rectum. Most of the time, these infections actually don't have symptoms, but sometimes they do, and the symptoms usually develop 5 to 7 days after the infection, and gonorrhea and chlamydia can affect the mouth, the genitals, and the anus. Another STI that can occur in the anal area is syphilis. Probably about 20 years ago, syphilis was nearly eradicated, and it's made a really serious comeback, especially in the last couple of years. The initial presentation of syphilis is a painless ulcer called a chancre, and this is what that might look like on the anal area. And you can see this looks like something that would really, really hurt, but it doesn't. And so this is actually be a really obvious case because it's typically painless in syphilis. And this is diagnosed with a blood test and treated with an antibiotic injection. Herpes can also occur in the anal area. Herpes typically appears as blisters, and we think of it on the mouth as cold sores or on the genital area as genital herpes. In the anal area, usually those blisters burst before I see the patient. So I see these ulcerations that look like this. And that will be typically very, very painful. Usually if I touch the patient's jumping off the table, they might get some burning, itching, and bleeding sensation. And you can get herpes type 1 or herpes type 2 on the anal area. Anal warts is a manifestation of HPV infection. HPV is human papillomavirus, which is a sexually transmitted virus that everyone who's sexually active is exposed to. Fortunately, the minority of us, probably around 2 to 5%, will actually develop warts, while the other 95 to 98% of us are just going to walk around not knowing that we have this. This is a different orientation of warts where we see a couple scattered areas instead of one big wart. And these can be treated in a number of ways, from creams and ointments that I might prescribe. Sometimes we freeze them with liquid nitrogen spray or burn them or surgically remove them in the office. Getting a little bit deeper into anal HPV. Anal HPV can cause anal cancer, just as it causes cervical cancer in people with cervixes, and head and neck cancer, which can affect the general population. Anal cancer is really rare. These are rates of cancer in the general population. And you see anal cancer is really, really uncommon compared to these much more common cancers. When we start to look at certain risk groups, specifically MSM, which is men who have sex with men, so this might be gay men, bisexual men, or anyone who identifies as a man and is having sex with another man, we see a much higher rate, so much closer to something like colon and rectal cancer that we routinely conduct colonoscopies for. And then when we look at people living with HIV, which is LWH, and these are non-MSM, so women and men who have sex with women and other populations. So we start to see an uptake there. When we combine those risk factors, though, and we have men who have sex with men living with HIV, we see really high rates of cancer of the anus, higher than any routine cancer that we screen for, like breast cancer or prostate cancer or lung cancer. And so we don't just sit around and wait for people to get cancer. We can actually screen for and treat pre-cancer with a test called an anal PAP, which is very similar to a PAP that the gynecologist might perform on the cervix, but here we're doing the same in the anus. There's no national or international guidelines for this, but it is a very common practice. And the research leading to those guidelines will probably come out in the next 5 to 10 years, and I'll talk a little bit about that. If the PAP is abnormal, then we can take a closer look with an exam called high resolution anoscopy. And this is very, very similar to what happens at the gynecologist with cervical cancer screening. And we can find and treat precancerous areas. So I'm going to go into some detail on here because if you're shadowing me in my office, this would be the procedure that you'd see me performing the most. So this is a cross section of the anus and rectum. So if we cut you in half, this is what all of our insides would look like. This squiggly line is called the transition zone, and that separates the anus, which is skin, from the rectum, which is intestines. And then I'm going to reorient this. So if we cut across, and saw the sort of where the rectum and the anus meet, this would be that same picture. So there's that same squiggly line, and then on the outside, let me see here. On the outside, that sort of more pearly tissue is the anus, and in the middle, that red coarser tissue is the rectum. So we're looking at this through an anoscope, through that binocular device that I showed you earlier, and we're looking for any precancerous areas. We apply two chemicals. One is simply acetic acid, which is vinegar. The other is iodine. And then just to orient you, what we're looking at again, so posteriorly towards the tailbone or coccyx, anterior towards the perineum or the skin between the anus and the genitals, and then left and right. So here's the transition zone again. I'm going to start to look along the anus and the rectum here. So I apply the iodine, and if you've used iodine in a science class or biology class, you know that it gets really dark on normal skin. And so that happens in the anus as well. And so here's another area where we're looking at the anus and rectum. We apply the iodine to it, and it gets really dark. So we know that that's all normal tissue, so that's great. And then as we move along, we see this area here. And if you look really closely, you can see some really superficial blood vessels that look like little dots. And there's some dots in here. And then there's some sort of mosaic looking stuff where you can see there's like blood vessels crossing each other. And it looks like a mosaic pattern, like tile. And we see different patterns like that throughout this whole area. And then we're going to apply the iodine to that same area. We see that instead of turning dark brown, that area turns light and yellow. And so this is an area that is potentially precancerous. This is another example where I have the circle. You can see it's a little more white than the surrounding tissue. There's some blood vessels in there. And so this is an anal precancer. This can be treated much in the same way as anal warts. Both of these are HPV-related disease, so it makes sense that we treat them similarly. And so again, that might be creams or ointments I prescribe. Sometimes we burn it, sometimes we surgically remove it. Our colleagues in Australia screen for this, but they don't treat it. And the reason is that the majority of these precancers will never go on to become cancer. About 1 out of 370 will go on to become cancer. So we end up treating 369 of these to prevent that one case of cancer. But if you're that one person who gets cancer and you have to undergo chemo and radiation, especially if such a sensitive organ, you can imagine how miserable that is. And I'm going to come back to that when I talk about my clinical research, because that's what's going to help determine how we should screen for this widely. And we can even better yet prevent anal cancer and all kinds of HPV-related disease through vaccination. So HPV vaccination is widely available and is recommended routinely for 11 to 12-year-olds with recommended catch-up vaccination up to age 26 and approved for up to age 45. And sometimes it's appropriate for that little bit older population. People who had the older vaccine, which was originally called Gardasil, do not need to be revaccinated with Gardasil 9, which is the current HPV vaccine. So how does this intersect with sexual health? So here's another cross section. So we're cutting you in half again. And there's the rectum, which is where we were just looking. And then I'll orient you to the rest of this. So there's the anus. So this is where we're looking on the outside. And then this is the prostate. The prostate's a little gland, and you see it right underneath the bladder. That big red triangle above the prostate is the bladder, and then the urinary stream comes through the prostate. When we think about anal sex, often the prostate gets all the credit. Stimulation of the prostate causes sensations of pleasure, and so people enjoy that. But there's a little bit more to it. And so of the anal area, there's a whole lot of nerves there right at the opening. And so there can be a lot of pleasure from just stimulation of that anal area. Additionally, back towards the rectum, the very base of the penis, called the penile bulb, butts up against the opening of the rectum. And so there's some stimulation of the penis as well during receptive anal sex. And what about our patients who don't have penises? So we might see a clitoris, which is approximately there. And then from the clitoris, there's these two nerve bundles that wrap around either side of the rectum called the clitoral legs. And so those clitoral legs are very much stimulated during receptive anal sex as well. So based on all of that, it should not surprise you that anal sex is not just among gay men or men who have sex with men. It's a really common practice in the general population. About 30% of people who identify as heterosexual do report engaging in anal intercourse. And condom use is fairly infrequent. A lot of times condoms are used for contraception or birth control rather than using them for STI prevention. One of the problems with that is that anal sex is the most effective way to transmit HIV sexually. So this is estimated risk of HIV transmission from an infected source, and you see the receptive anal partner has a very, very high risk. It's 17 times higher than the risk with vaginal sex. And even the insertive partner during anal sex has a lot of risk for HIV. We can also prevent HIV. And one of the ways that we do that is with PrEP, or pre-exposure prophylaxis. And this is a prescription medication. There's two brand names that are FDA approved, called Truvada and Descovy, and these are extremely effective at preventing HIV infection. Over 99% effective. There's about 500,000 people in the US on these prescriptions, and we only know of a handful of cases, probably less than 5, where people have acquired HIV while on this medication. There's a study that looked at side effects of aspirin versus side effects of these drugs and showed that aspirin actually had a lot more side effects. So something that's so simple and over the counter and so many people take. So it just shows you how safe these medications are. And then when we compare this to something like birth control or contraception, hopefully we'll get to a point where we have a lot of options. So everyone can sort of pick their HIV prevention option that works for them. And that might be PrEP pills, that might be condoms. But I think we'll see in the next year or two probably some injectables, maybe a vaginal ring, and maybe we'll see like a vaginal ring combined with a contraceptive or a birth control. So a lot of cool stuff happening here, but it's really, really important that we're getting people who are at risk for HIV on these medications. There's around 40,000 new HIV infections every year in the US. It's a lot of people. All right, I'm going to get into some of my clinical research here next. So we had talked about the anal precancerous areas that we can identify and treat to reduce the risk of someone acquiring cancer. And I had mentioned that in the US, we treat these areas, but our colleagues in Australia don't. And throughout different parts of the world, there's different things that we do. And so the NIH, National Institutes of Health, which is part of the US government, has funded this huge trial to decide what we should do to screen for anal cancer. And my office happens to be one of the sites for this. So in this study, we're looking at, can we prevent anal cancer by screening for and treating anal precancer in an at-risk population? So in this study, we'll enroll over 5,000 people. At my office, we have about 500, and then there's 13 other sites through the US. And we'll follow people for 5 years. And so we enroll people who are anyone over the age of 35 living with HIV. And we do that exam that I just showed you, where we can identify HSIL, which is precancer. And if those people have HSIL found, if they have precancer, then we enroll and randomize them. And what that means is that they become an official study participant. And randomization is like flipping a coin, where if it lands on one side, they're in one group, and if it lands on the other side, they're in the other group. And I'm going to compare this to the COVID vaccine studies just because it's really relevant right now. So if we randomize a COVID vaccine group, we would flip the coin. One side says you get the COVID vaccine, the other side says you get just a placebo injection. And that way the participant doesn't know whether they're getting the real vaccine or placebo, and the provider doesn't know whether they're getting the real vaccine or placebo. Back to the anal cancer study. So the two groups that we have are observation and treatment. So either way, we see the patients every 6 months. We do these same types of exams. The only difference is in the treatment arm, we're going to actually treat those precancerous areas. And so these patients fall into my schedule. I see patients every 20 to 30 minutes because they're heavily procedural. So I have a lot more time with my patients because I'm doing invasive procedures on most of them. But these patients just fall right into my schedule. I don't schedule them any differently. They're not a specific day. I don't go to a different office to do it. It's the same staff, the same equipment. The paperwork is a little bit different because they collect paperwork in a sort of binary system for clinical research so that they can come up with outcomes. And what we're doing at our site is exactly the same as what they're doing in Miami and San Francisco and Boston and Chicago, so that all of these sites are doing the exact same research. So we'll watch these people for 5 years and see where we find cancer cases. We know that when you treat someone for precancer, that some people will still develop cancer. So we don't know that that's actually going to be the better option. But the real question is going to be sort of, does it make sense, or are we doing more harm by putting people through all these invasive procedures than we are by preventing those few cases of anal cancer? So that's how clinical research plays out in my office. I'm going to come into advocacy in a number of ways. And I think the fact that you've all participated in these pre-health shadowing opportunities, you understand how important it is that as a healthcare provider, there's more than just seeing patients. And so I'm going to look at advocacy in a number of ways. This is me and my colleague Mia McDonald, who's another PA at an event in Washington, D.C. that happens every year, where about 300 PAs go to Washington, D.C. For a 3-day meeting, and 1/2 day of that, we actually go to Capitol Hill. We go to our senators and our governor's offices, and we talk to them about issues that are facing PAs. And the issues last year, this occurred in March, right before the whole world went up in flames. And so I met with Senator Gillibrand's office, Congressperson Chuck Schumer, some names that you may recognize who are pretty big names in the political world, and talk to them about Medicare billing for PAs to make sure that we could give our patients the best possible care. And so that all occurs through a group called AAPA, which is the American Academy of Physician Assistants, and they're the national advocacy group for PAs. And then you have other groups within that. The LBGT PA Caucus is the LBGT group within the AAPA. And then you have groups outside of the PA world that you can participate in, like GLMA, which is Health Professionals for LGBTQ plus Equality. And so these are some of the advocacy groups that I take part in. I'm currently president-elect of NISPA, which is the New York State Society of PAs. And a state organization is really essential. PA practice, and actually all medical practice, whether you're a PA or a nurse or physician or whatever you are, is all determined at the state level. So what I can do in New York might be different from what I can do in Pennsylvania, is different from what I can do in Kentucky. And the current differences are probably less and less, but when I went to PA school, PAs couldn't prescribe in about 10 states. And thanks to the advocacy work of groups like NISPA, all states have come into PAs prescribing, and that's a huge access to care issue that's been overcome. So these are two of the board members with me who you may recognize from Instagram. Family Med PA is Mike Sachs, and Joe the PA is Josie Avaro. They're both on the board of NISPA with me. And so through NISPA, we're advocating at a state level, going to our state senators' offices virtually at this time, of course. In addition to a lot of other things, we do scholarships, we do continuing medical education conferences, and stuff like that. Another way I get to advocate is through mentorship. We don't allow shadowing in our office because it's really sensitive. But what we do is our staff is all people in their gap year. And they come work with us usually for 2 years. We sort of get to train and mentor them and help them get into health professional school. So some of my colleagues, this is Andrew. He's currently in PA school at GW. This is Lily. She went to Einstein for medical school. This is James. He went to Cornell for medical school. And you see all of these great people that I got to mentor. And actually, none of them are still with me any longer. They've all gone on to professional school, and I now have a whole different group with me. All right, and then two more things that I really love doing in terms of advocacy is publishing and presenting. So obviously, I have very specific and unique work that I do that a lot of people might not be aware of. I would imagine the majority of you have never heard of an anal PAP. Not surprisingly, many of you probably haven't heard about a pill for HIV prevention. And so it's really important to me that as I work in this field that I can share that knowledge with a lot of other people. So one of those ways is presenting. This is me presenting at the AAPA National PA Conference about anorectal pathology. And a lot of the slides I use today are actually from that. And then publications really important to me as well. This was the article I published in the Journal of the American Academy of PAs a couple of months ago, updating on how to prescribe PrEP. And this came right after the second drug for PrEP, Descovy, was approved, so that I could give my colleagues the knowledge that they need to prescribe this in their different practices. This was a piece of that paper that I was particularly excited to do. So none of this is original research, but one of the things that I did when I wrote this paper was I really intentionally wanted to remove gender from the picture. A lot of times we think of HIV transmission, this is what happens for gay men, this is what happens for women, this is how we approach different populations. I wanted to break this down to, let's take gender out of the picture. So if someone's a man or a woman or non-binary, or transgender, or none of the above, or all of the above, what are risk factors for HIV? And came out with this list of living in an area where there's a lot of HIV, not being able to use condoms consistently, and a number of other risk factors, but all of them totally separate from gender, race, ethnicity, all of those things that we often categorize people in. This was an award that I won in clinical publishing from the AAPA for my work in HIV prevention. And this was really cool to me that this was a thing important to me, but I was so excited that it was so important to AAPA, and that the National PA organization was recognizing work that was really focused on this diverse and minority population. World AIDS Day just occurred on December 1st. In my practice, I don't treat HIV, but about half of my patients are living with HIV, and I don't treat them any differently than my other patients. Or maybe if I do maybe treat them a little bit better, because the majority of them have been through pretty traumatic experiences in the healthcare world. And so this is another way that you can really advocate for your patients. I talked a lot about sort of advocating for myself in my profession, but at the end of the day, it comes down to patients, and to advocate for them is really the most important thing. This was a really fun event that I got to do in the middle of COVID. This was in June or July, I think. This is a drag queen named Sherry Vine, who's, should any of you happen to interface with the drag world, she's a pretty well-known drag queen artist. And she put on a show that was all about butt stuff. And she brought me on for about 10 minutes to just answer some questions having to do with anorectal health. So it was a really fun experience to get to sort of reach out to my community. When I do these presentations at conferences, that's for a bunch of PAs. I hope they take that back to their communities. This was me getting to advocate with my own community, and talk about these concerns. So with that, that is the end of my presentation. I'm really excited to answer some of your questions and share whatever bits of my experience that I have. So thank you.
Thank you so much for that talk. And if anyone wants to ask Jonathan Baker a question, feel free to drop any questions in the chat and we will ask them. And the first question is, what is your biggest piece of advice for someone looking to pursue LGBTQ plus medicine?
So it always comes down to passion. If you have a passion for something, you'll find a way to make it happen. And I really genuinely believe that, but it's not always easy. I talked about my journey and I sort of fell into it. And I was very lucky to fall into that first job. But if you have a passion for something, that is something that you really just want to build on. And so I'll give you an example. When I was in Pittsburgh doing my work there, we did some HIV prevention research, and I came into my new office here, and they weren't prescribing PrEP. It just wasn't part of the office because it's a colorectal surgery practice. And I said, hey, I want to prescribe PrEP. I think this is really important for our patients. And the collaborating physicians I work with said, absolutely, go for it. Let's build this into our practice. For a lot of my colleagues who work in LGBTQ health, they work in these centers that you can find in a lot of urban areas, like Callan Lord in New York City or Fenway in Boston, that are really focused on LGBTQ community. But there's also something really powerful about working in somewhere where those don't exist. So when I was in Pittsburgh, there wasn't a huge LGBTQ health center. And so I was sort of the LGBTQ provider there. And my patients were really happy to have someone who understood them. So there's a lot of different ways to do it. But if it's something you're passionate about, absolutely pursue it, work hard at it, and you'll get there.
Thank you. The next question is, what made you choose PA over other health professions?
Really good question. It was a number of things, and ironically, none of them ended up being the things that I love about the profession. So I found out about PA and had an understanding of, number one, less school, and being a 17-year-old, I was like, oh, cool, less school. I'm really excited about that. I felt that it was a little bit more patient-centered, and I think that that's actually increasingly the case. I think physicians tend to get bogged down with a little bit more paperwork and other responsibilities, but that's not always the case. There's a bit of a myth of work-life balance, and work-life balance is just whatever you make it. But when I was 17, it looked like PAs probably had a better work-life balance. But one of the most important things was flexibility. So PAs are the only healthcare providers other than physicians who have unrestricted licenses. So we can see pediatric patients, we can see elderly patients, we can see cancer patients, we can assist in surgery. So we can interface with all parts of medicine, and we can move really easily. So I didn't do a residency in colorectal surgery, I didn't do a residency or a fellowship in sexual health, and I can easily move from field to field. I know people who have gone from actually my office currently, and then went to bariatric surgery, and now is teaching PA school and does orthopedics on the side. So that flexibility to sort of switch specialties was really, really important to me when I was looking at what I wanted to do. Ironically, I've been now in the same specialty for 11 years, but I found something I love, and I don't regret that at all.
And the next question is, are those who partake in anal sex supposed to get routinely checked, like a routine checkup with people who start vaginal sex, like going to the GYN?
There really is no standard of care for this, unfortunately, and hopefully I showed you the anchor study of the clinical research at my office. My hope is that that will help give us a better idea of what really needs to happen there. In medicine, it's all about figuring out what sort of has the most benefit and the least amount of risk. So we could do MRIs and CT scans on everybody every 6 months, and whenever someone had cancer, we would find it really quickly. But we would then expose everyone to so much radiation, and that would probably end up causing more cancer in the long run. And so same sort of thing with what I'm doing is, like I said, only 1 out of 370 of these areas become cancer. So am I actually putting through all of these people through invasive procedures that they don't need to prevent that single case, and figuring out where that balance lies? So my recommendation is, at this time, without any national guidelines, that people who are engaging in anal sex should make their healthcare providers aware if they think that they're safe to make their healthcare provider aware. And probably an annual rectal exam just with a finger is important. Rectal exams used to be for prostate screening. That's less and less the case. because the research showed that that was actually a pretty ineffective way of screening for prostate cancer. And so a lot of times it doesn't get done at all. But if you're in a situation where you're comfortable talking to your provider about anal sex, then it's something that probably should be done about once a year with those visits.
And the next question is, can you talk about why you chose Duquesne for PA school?
Yeah. So I'm from Cleveland originally. And I looked at stuff that was sort of close enough and far enough from home. And I actually didn't love any of the schools. I liked Duquesne a little bit because it was in an urban location. It's right in downtown Pittsburgh. But the biggest draw for me was the accelerated nature of it. So it was a 3+2 program, like I mentioned at the beginning. So in my fourth year of undergraduate school, I was already taking my PA courses, and then again graduated at 22 and was doing the work that I'm still doing now. So that was the really important thing to me. Yeah.
Thank you. The next question is, have you ever been discriminated against the kind of research you do by other professionals or people outside of medicine? And if you do, how do you handle those situations?
That's a really good question. So one of the stats I threw at you at the beginning was 56% of LGBTQ individuals have been discriminated by healthcare providers. I am in that 44% who really has not had a traumatic experience. My publishing and presenting career really kind of took off in maybe 2014, 2015, and has like peaked this year, especially with virtual conferences. And I have to tell you that whenever I submit something to a conference or talk to someone who's a faculty at a PA program, they're so excited to have this totally new and different area of medicine to share with their audience, to share with their students. I'm sure that at some point in my career, someone's looked at my resume and said, absolutely not, with all of this gay stuff all over it. It might as well be on a rainbow piece of paper. I have no doubt that at some point in time, someone's passed me up for something because of that. But in all reality, it's really, LGBTQ health has become a really hot topic. And I'm really happy about that because it's such a contrast to what it was when I was much younger.
And the next question is, what was your most memorable case?
Let me think on that. Will you ask me another question? And I'm going to just let that simmer in the back of my mind for a minute.
Yeah, no problem. The next question is, what helped you get through PA school?
Two friends was everything for me. So I had met, by the time I got into the actual like graduate program, I had already met everyone who's going to be in my class with me, with a couple of exceptions. There's a couple of open seats. And two of those people became like my best friends, study buddies. We would just spend all day together and all night together. And it wasn't like we were doing fun things. We were just like studying all the time. So having that community within your class is really important. Coming from a minority standpoint on that, if you don't have that community in your class, then I really encourage you to find it somewhere else. In 2020, we are very virtual. You all found out about this, I imagine, through Instagram. And so there's a whole community out there, really, really great people. So if you don't have that community in your class, go find it somewhere else. And that might be in a Facebook group, that might be in an Instagram group. The other thing that got me through it was not being 100% focused on PA school. So I still did theater actually throughout my whole time in college. I don't do it anymore because I'm not good at it. But I go to a lot of Broadway shows when they're open. And so having some outlet, having some creative outlet, having something other than professional school is really, really essential. And that might be theater for you. That might be something totally different. I'm going to go back to my memorable patient case. So I knew I had one. It was just like not coming to my mind right away. And this was a patient who had anal precancer many, many years ago. And it was picked up on a colonoscopy, which doesn't happen very frequently, but occasionally it does. And they were sent to a colorectal surgeon who could care less that this patient was a gay man, and could care less that his anus was a sexual organ, and absolutely just butchered him. He removed the precancerous area, but in that caused really significant scarring. And this patient lost his anus as a sexual organ. He can't have anal sex anymore. It's not part of his life. And that's something that you can move past to some extent. You might enjoy oral sex, you might enjoy other kinds of sex, but pretty traumatic to lose your sexual organ in a medical procedure. And so he comes to us for follow-up because cancer can recur, right? And so we're screening him for precancer. And I'm seeing him for the first time when I'm new to the practice. And we have like a little sticky note on the chart that's like, this patient's been through a lot and will probably cry during the exam because he's been through so much trauma. And fast forward a couple of years, I'm seeing him and he's absolutely fine. He doesn't get upset during the exam whatsoever. He makes it through the whole thing fairly comfortable and finishes, and then actually like starts to well up a little bit and say like, I can't believe that I actually am so comfortable with you that we were able to do this procedure without it being as traumatic as in the past. And it took us a couple of years to get there, but it was really, really cool to be able to be there for a patient and hopefully reverse some of that stigma that he's experienced through healthcare providers.
Thank you for being so open.
Thank you so much for sharing that. And the next question is, did you participate in or publish in any research prior to PA school?
No, I did not. I actually hate writing. It's one of my least favorite things in this whole world to do. And I never had an interest in it. And a colleague like really, really pushed me to do it multiple times. And it probably took me like 3 years to write my first paper. And then recognizing that this was going out to 50,000 PAs throughout the US, and that they were going to interface with this. My first published paper was HIV prevention. And to know that they were going to interface with this paper about HIV prevention in probably a way that they've never seen before. And they probably were thinking of HIV like it was 1986, which is often how HIV is taught in health school. I was really excited by that. And so I went more so the way of presenting because I like presenting a lot, and I don't like writing, but I keep writing because it's something permanent. It's something people can go back to. And that list that I showed you of HIV risk factors, regardless of gender, sexuality, race, ethnicity, that's actually now gone into policies for a couple of organizations. And so unfortunately for my dislike of writing, publishing is a really important part of that. But I didn't do anything prior to school. I learned all of those skills either in school or by working with people who are really good at it.
And the next question is it hard to stagger your time between practicing medicine and conducting clinical research?
No, not at all. So the clinical research of the matter is really, really minimal for me. Again, those patients are just jammed in there with my normal patients. So this morning, it was like my first patient was a procedure, my second one was a follow-up, my third one was a research patient, the next one was another procedure. And it just falls in line. It's a little bit more paperwork, but medicine, unfortunately, to tell you all this, is so much paperwork to start with. So a little bit more is not a big deal. When it comes to actually like writing or presenting, that is not part of my job. That's something that I do on my own. So I often do that on nights and weekends. Pretty frequently, I'll get up Saturday morning and just like work basically an 8-hour shift at home. That's writing and finishing presentations and doing this, that, and other thing, or work for one of the organizations. But the clinical research itself, like the anger study, that just falls in my schedule very seamlessly.
The next question that we have is, how do you explain to non-medical friends what PAs are and how they fit into the medical field?
That's a great question. So this is always a struggle, and a big reason for that is PA stands for physician assistant, and the work that PAs do is not assistant work. And so next Friday, I'll be in my office. Neither of the physicians will be there. I will see every single patient on my own. Any phone call that comes in the office, I will take. Any prescription that needs written, I will write. Any procedure that needs done, I will do. And if I desperately needed something, I could contact either of the physicians by phone or by FaceTime, but neither one of them will be anywhere near the practice. And so to have the word assistant in my title is so absolutely ludicrous. And that's something that the profession is looking at as a whole is, should we actually change our name to something else, which is a much bigger production than you can possibly imagine. And so when I'm trying to describe it, it depends on the setting and what I'm trying to convey to someone. So if it's a patient, which is probably the most common opportunity I have to explain the profession, I usually just explain, I went to school to become a PA. I got a master's degree. We work with physicians and other healthcare providers as part of a team, and we write prescriptions, perform procedures, and do all of the things that the physician that we can work for does. And in New York State, that's how the law is laid out. So whatever physician I work with determines my scope of practice. So whatever they do, I can do. So that is how I describe that.
Thank you. The next question is, what else should pre-PA students be doing besides volunteering and shadowing to make themselves more competitive?
So when I went to, you're all younger than me, everyone I can see is. When I went to PA school, I filled out an application on a piece of paper, and I mailed it to the school, which seems so ridiculous to me at this point in time, especially in 2020. And it was very competitive, but it was not at the same level that it is now. I actually had no healthcare experience whatsoever, which you'd be very hard pressed to get into a PA program without healthcare experience. I'm not faculty. I am faculty of PA program, but I'm not. I don't do admissions for them. I don't pick who's going to be in the program and who's not. But I do pick in our office who's going to come in through their gap year and work in our office. And my biggest thing is always, what has this person done outside of medicine? What's going to make them a well-rounded person? And if they've spent their entire life solely focused on medicine, I'm thinking like this person's probably going to be dry and they're probably going to be burned out. If I see dance, if I see singing, if you're in a show choir, and of course I have a personal bias there. One of my staff that I was completely gung-ho on hiring was a very successful football player. I was like, if he played football and got a 3.8 through undergrad, absolutely, he's going to be great. And he was a very interesting addition to our practice because he was a very kind of jock guy, but he actually ended up being one of the best staff I've had, and probably knows more about gay men's health than the majority of healthcare providers. So I really think that one of the things that often gets missed is whatever your extracurricular stuff is, and your volunteer work might be healthcare volunteering, but I would also really encourage you to do volunteering in other ways, whether that's like a soup kitchen or even with a religious community or whatever.
You've talked that you work with a team, like you've talked with the doctors. Can you talk about the dynamic and who you work with and other health professionals you work with?
Yeah, so my office has 10 people that work there, the 2 surgeons, myself, practice manager, and then all of the gap year staff. We don't have any nursing, which is unfortunate because nurses are a really valuable member of the healthcare team. It just doesn't quite fit in with our practice. I think if we grew, we would probably need a nurse at some point. In terms of my interactions with the physicians, as I mentioned before, it's pretty minimal. I'd say probably once a month, I bring one of them in to see a patient who I'm particularly worried about, or I just don't know what's going on. And probably about once a month, they'll pull me in to see a patient where they want to confirm what they're thinking. Especially if it's a sexual health kind of thing, they'll often rely on me since they're both colorectal surgeons. In my prior job when I was in Pittsburgh, that was a much bigger group. It was probably about 50 people in an infectious disease clinic, and I worked very closely with the nurses and the medical assistants. So healthcare is all about teams. It's really, really important that we rely on each other. And that team can be structured in so many different ways. In my current practice, I'm responsible for all of the staff, which is the majority of the people who are working there. And so I'm really like the person who makes sure they're doing what they need to be doing, and helps train them when they need training or support. And the physicians just sort of like see their patients, and we're like ships in the night, passing by each other in the hallway.
Thank you. And the next question is, how many patients a day do you usually see, and what kind of hours do you work?
So I am a huge proponent that it is our personal responsibility to not burn ourselves out. And so I will not work in my office more than 40 hours a week. And that is something that I have always and will always stand very strong with. And I mentioned I might work 8 hours on a Saturday on presentations and stuff. That's my own choice. But I will never work those 8 hours on a Saturday in my practice. Just to do that, because you don't want to burn yourself out. I've been in the same field 11 years. I see the same stuff every day. I see the same patients. I could be this close to burnout, but because I don't push myself to work crazy hours, I think that that's really, really helpful. So generally I work 40 hours. It's Monday through Friday. I really enjoy having that sort of Monday through Friday weekday schedule. Other people really enjoy having, working like evenings and overnights and stuff. I don't see as many patients as most PAs or most healthcare providers because we do so many procedures. And so I really need that extra time, and those procedures also pay more. So whereas a counterpart of mine might see, 5 or 6 patients in an hour, I'll typically see 2 or 3.
Thank you. The next question is, someone dropped in the chat, what are the differences between HSV1 and HSV2?
Yeah, so HSV is herpes simplex virus, which the closed captioning changed to HSB. So HSV1 is herpes simplex virus. This is a group of viruses transmitted by skin-to-skin contact, and there's 2 strains of it, 1 and 2. HSV1 is less likely to cause symptoms, and the majority of people get HSV1 in childhood, and it's often spread from just kissing family members, whether that's parents or aunts or whatever, and just very kind of casually spread in that way. So about 70% of people get HSV1 in childhood. That number used to be higher, and so later in life, we would then have antibodies to HSV1, and we won't get it other places. 30% of the population who don't have those antibodies can get it other places. So we actually do see some genital HSV1, and we see a lot of anal HSV1 as well. The good thing when that happens is that it's less likely to cause recurrent symptoms. HSV2 tends to be a lot more symptom causing, or virulence is the word for that. People don't get HSV2 in childhood, or they certainly shouldn't. And so we are much more susceptible to that later in life. And so people who don't have antibodies for HSV2, so they end up getting it on the genital and anal area. In general, there's not a huge difference. It's really just that difference epidemiologically of a lot of people get HSV1 in childhood and have it on their mouth. But in all reality, it actually affects the mouth or the genitals or the anus pretty equally.
Thank you. The next question is chemotherapy and radiation fairly effective for anal cancer, or does this particular type of cancer tend to have a higher mortality rate compared to others?
So anal cancer is very easily treated. And if you catch an anal cancer very, very early, we can actually just remove it because you don't have a whole lot else that's right up next to the anus. And so what a cancer is when cells start dividing, but there's no checks and balance system. So it's just like one type of cell keeps dividing and dividing and dividing and builds what we call a tumor. And then once that tumor goes into another surrounding tissue, it becomes cancer. And that's the definition of cancer anywhere, including in the anus. And so some of those cancers, like in the pancreas, everything's around the pancreas. So that invades something else and it's a disaster and it's very high mortality. In the anus, it's slower moving. There's not a whole lot around it. So it's actually really easily treated. The problem is that people don't like to come to healthcare providers with anal complaints. They don't want to show up and say, oh, I feel this bump in my rectum. They don't want to get examined. And then the providers often don't want to examine them. And they'll just say, oh, hemorrhoids, go get preparation H over the counter. And so a lot of times, and a lot of these famous cases of anal cancer that you may hear about are people who have anal cancer for years and years before it's ever diagnosed. And at that point, it's too late. Once it metastasizes, which is where those cancer cells get into the bloodstream or into the lymphatic system and then spread throughout the rest of the body, any cancer becomes very, very difficult to treat at that time. But anal cancer itself is actually just really easily treated. We just need much better screening protocols for it.
Thank you for that. And the next question is, what organizations do you publish papers with? And do you have any help in any part of the process?
Yes, tons and tons of help in all parts of the process. So most of my publications have been through the Journal of the American Academy of PAs, or JAAPA. And this is a journal specifically for PAs, and it's distributed to everyone who's an AAPA member, which is, I don't know what the numbers right now, but probably about somewhere between 50,000 and 80,000 people. So a pretty huge number of people get this journal. And what I really love about it is their journal is very clinically focused. So if you've read journal articles that are really dry and have tons of numbers and charts and you're just like, your eyes are rolling, that's not what JAAPA publishes. JAAPA publishes really clinical stuff. So like the prep paper was like, here's the labs you're going to order when that patient wants to start prep. Here's the side effects you need to tell them. Here's how you're going to deal with cost and insurance issues. You're going to see them back in 3 months, and you'll only discontinue them if this, that, or the other thing happens. And so that's why I specifically publish in that journal, is because it's stuff that's really clinically applicable. And then it goes out to so many people, and they can have that article sitting on their desk. And when that patient comes in and they're eligible for prep, they have that resource right in front of them. And then I do have a ton of help along the way. I've published a couple of things on my own, but typically I work with someone else. And it's really helpful to have someone else's perspective and someone else to bounce off of. And then when you submit to a journal, there's a peer review process where typically 3 people with similar credentials than you will review the paper for accuracy and typically make suggestions. So on a typical paper that I published, I worked on it, I worked with someone else on it. A lot of times I'll have maybe a third person who's a friend just look over it really quickly, goes to the journal, then 3 more people look at it, and then it gets published. That also means that whole process takes typically about 12 months from conception to publication.
Thank you. The next question is, are all anal warts caused by HPV?
Yes. All anal warts are caused by HPV. All warts are caused by HPV, but the strains that cause anal and genital and oral warts are different than the ones that cause warts like on the foot or the knees, but they're all human papillomaviruses. You can have other things that look like warts that are like skin tags, and there's about 1 billion other things that can look like warts, but actual warts themselves are always caused by HPV. And those strains that cause warts are not the ones that cause cancer.
Sorry, thank you. The next question in the chat is, did your program talk about anorectal specialty in LGBTQI advocacy openly, or did you have to learn it outside of your program?
I learned it mostly outside. So our program, I mentioned the school is a Catholic university. I was there during an election year, and everything was Republican, which is what it is. You have political differences, but that tends to be a little less focused on LGBTQ stuff because of that. The program itself was very liberal, and the program director worked for an HIV study as her clinical job. So it was sort of like this little liberal island in an otherwise conservative environment. So in that environment, we got a little bit of exposure, but not a whole lot. What I was really fortunate to do is I had been an advocate for LGBTQ populations, not necessarily health, but just for my community as a whole for a very long time. And so I really wanted to do my elective rotation in LGBTQ health. And my clinical director happened to like me, and I asked her if she would set something up. And she worked really, really hard to find me something, and had come up with a couple of options. And ultimately, my last rotation was at the Gay and Lesbian Center in Los Angeles. And it was a really incredible experience. I learned so much, and it definitely told me that was what I wanted to do. So if there is something that you're interested in, you have to really impress your clinical coordinator to have them do something like that for you, especially now. I think their jobs are getting harder and harder every year. But you can also find rotations on your own. And I would really encourage you to start thinking about that whenever you get to that phase, if there's something you're really interested in. And people in these areas tend to be pretty passionate. Again, I don't take students, but most of my colleagues in other LGBT centers do, because they love the work that they do, and they love to pass that on to people who are willing to learn it.
Thank you. The next question is, what is the hardest thing that you find yourself doing at work?
I'm annoyed by the amount of paperwork that I do. For every patient that I see, I sit at my desk for probably 5 minutes and type their notes, make sure that they're accurate, or have phone calls with the results, or report things to the Department of Health, or all of these things that are non-patient care that drive me crazy. The other thing that I'll mention that I find that's really hard is being selfish in the workplace. So it's really exhausting to see people every 15, 20, 30 minutes or whatever, and have them tell you what their problems are. And meanwhile, like, who knows what's going on in your life. And so it's really exhausting to do that for 40 hours a week, every week for your whole life. And I'm saying this to focus a little bit on like the burnout stuff I talked about. It becomes really easy to become selfish and think like stop whining, stop complaining. Like, I've already told you how to treat this. You didn't adhere to your medication. And so one of the things I've been really trying to push myself is if I prescribe someone a medication and they don't take it, is thinking what came up in their life that they weren't able to do that. Like, this, it's not them necessarily being irresponsible. Most of the time, it's probably not. Maybe their child got sick. Maybe they had transportation issues. Maybe they got to the pharmacy and it wasn't in stock, and then something else came up. And so I think it's really important that as healthcare providers, we just appreciate that patients are going through all these other struggles in their life outside of what you're seeing, and keeping that mentality so that you don't get sort of burned out and you don't get jaded, and just remembering each one of those people is a person, and they have their whole set of circumstances that you have no idea what they are.
Thank you so much for that. The next question is in the chat. Is there a reason why there's an increased risk of contraction of HIV during receptive anal sex?
There is. So two things. One is the anus and rectum is where your stool comes out of, poop. And poop is a whole bunch of bacteria. And so your body naturally has a million immune cells right there. because it's the most that your body's going to interface with bacteria in any place. And those immune cells are exactly the cells that are affected by HIV. So you're basically putting that target for HIV right where you're having sex. And then on top of that, there's always like microscopic tearing that occurs during sex. That happens fairly infrequently in the vagina. It happens very commonly in the anus. So you have tearing of the skin, and then you have this just like perfect spot where you have an opening that's just lined with immune cells that are the perfect target for HIV.
What are your thoughts on anal PAP for HPV?
So if we'll see what the study shows. The general consensus is that probably people living with HIV who have anal sex starting at age 30 or maybe a little later should start being screened with an anal PAP. And those who are not living with HIV having anal sex could start being screened at 40, but only if you have a provider who knows how to do an anal PAP, who knows how to do the exam that I showed you, and knows how to treat those areas. If you don't have access to all of those things, then absolutely do not do it, and it should just be a rectal exam once a year.
Have you ever dealt with imposter syndrome?
Yeah, I still deal with imposter syndrome sometimes. So imposter syndrome is the idea that despite your education, training, and knowledge, you feel like you're still inferior, and that you're sort of being an imposter, like you're acting like you're smarter or better or more knowledgeable than you are. But what defines imposter syndrome is that you're actually already smart and knowledgeable and educated. And so it's a complete disparity between reality and this thought process. And so it sort of comes across to me every once in a while, especially if I'm submitting something to like a huge conference, and I'm like, really, like I'm going to be the person to present this. But you know, if they I don't even know what else to say about this. It still happens to me all the time. My CV is 10 pages long, and I still feel like I'm experiencing imposter syndrome sometimes. And like even right now, like 153 pre-health people just like came to listen to me speak for an hour and a half. Like what is that? Why, like what's so great about me that happened? So it's a very, very normal thing. But if you're getting into a profession, you have to work your butt off to get there. And then once you're in professional school, you have to work your butt off to pass those tests. It is not easy. It is so difficult. I would probably do it again if I absolutely had to, but the thought of going back to PA school is so excruciating, I can't even tell you. And then continuing medical education and taking my boards every so often, you just have to remind yourself, like, you've done all of this. And whatever accomplishments you have to remember those. People tend to focus on what their weaknesses are, and forget what all of their strengths are. So think when you're having that imposter syndrome, think what would I say if my friend was feeling this? And you would absolutely be saying something very different to yourself in that situation.
That's great advice. Thank you. The next question is, why is it recommended to get a pap smear every 3 years rather than every year?
So that comes down to that risk to benefit ratio. So it takes an anal precancer to go from normal anus to a cancer. Takes about 5 years. And so you have normal anal tissue, precancerous area, cancer. And as best we can tell, there's about a 5-year period in there. And so by doing a PAP every 3 years, you're likely to catch it somewhere in that middle. If you do it every year, you're much more likely to catch it somewhere in that middle, but then you've probably done a bunch of exams that were totally unnecessary. And I show you these very disconnected images. there's someone on the other side of that camera with a scope in their anus for 10 minutes. It's not comfortable. And I take the biopsy and they bleed, and like it's not a pleasant thing to go through. So it's really just managing, trying to have the least sort of discomfort and least risk while having the most benefit. And that recommendation for 3 years is generally people without HIV. And people living with HIV, it's typically more like once a year.
The next question in the chat is, how do you manage your emotion when a patient is telling their traumatic experiences to you?
So this is really hard, and I mentioned that traumatic experience with the patient, and that was a little easier because it was spanned out. Like we had multiple encounters where we went from totally traumatic to like, I can't believe how comfortable I am with you. When it becomes really difficult is giving a hard diagnosis, like telling someone they have cancer or telling someone they have HIV. And in those moments, you don't like, it's not a spanned out process. It's like, this is happening right now. And I'm going to be the first person to see your reaction to this. And so I've given both of those diagnoses. Both are an absolute miserable thing to tell to someone. And the really key thing is you have to remember that, number one, you're trained to do this. You know so much more about the situation than this person you're talking to. And the absolute best thing that you can do for them is to be strong and hold up. If you break down, they're going to absolutely lose it. And so when I give these diagnoses, I'll sort of like pump myself up for like 10 minutes in advance. I'll write down everything that I know I want to say. When I'm actually going to say it, I'm going to lose that piece of paper and forget everything I want to say, but it helps me just focus and know what I want to get through. I give the person the news, and then I always just let them sit for a minute so that they can take it in and deal with it. And that minute's difficult. And everyone reacts to it differently. Some people will deflect and laugh. Some people will get angry. Some people will cry. Most people will just sit there with a total blank stare on their face because they're just in shock over the situation. And then I'll come in next with saying, like, basically, here's the prognosis. And most of the time, it's not that bad. Maybe we'll start you on medications, or we'll get you to see the oncologist or whatever. You want to have a plan for them so they have something to hold on to. And then you can give them little bits of information, but the majority, 90% of what you say in that encounter is just gonna disappear because they're totally shocked. And then you get the patient through it. I walk them to the front desk. I say, can you connect them with this person's office so they can get taken care of? And then I go to my office and then I cry for 5 minutes and just sort of let all of that out. It's extremely emotional, but the most important thing that you can possibly do is to just be strong for that person in that moment, because that's what they really, really need. I never give my cell phone number to patients, except for in that case. I'll give them my cell phone number because I don't know what their support network is. I might ask them that. They might give me a real answer or a fake answer. I don't know, but I want them to have someone that they can speak to if they need to. So you just really have to focus on, and it's one of those moments where it's like, this is why I went into healthcare, so that the person across the table telling them that they have HIV is me instead of being someone else who doesn't know what they're doing.
Thank you. The next question is, are you able to do procedures on your own, or does an MD have to be there?
Nope, I do all the procedures on my own. There's a very fine line between what I do and what's considered surgery. I don't do anything that's technically surgical, and that gets a little fuzzier. But again, next Friday, it's just going to be me in the office. So I'll do these anorectal procedures. I'll take biopsies. I may burn stuff. I may apply different chemicals or different acids. And that's, under supervision legally, so I could reach one of the providers if I needed to, but there's literally no one else on site other than me.
How did you manage stress in PA school and stress just in general?
So in PA school, having that support system was really, really important. And having the outlet was really, really important, like I talked about. Now, how do I manage stress? I'm like a very active stress manager. So when I'm like, I accomplish a lot when I'm very stressed. And so if I'm super stressed about something, I'll like pull up a project that I know I can like work on concretely and like do some work, and that really helps me. I had a therapist for a couple of months at the beginning of the year when things were really crazy. And this was actually right before COVID. It was just a lot was happening at work, a lot was happening with my organizations. And I did therapy for 3 months through Talkspace. So it's just an app-based thing. We do like video chats and we could text back and forth. And he really helped me establish some coping mechanisms and just different ways of thinking about stressful situations, which were specifically applicable to me. And that was really, really helpful. And I was really proud of myself for sort of letting that be a vulnerable situation of saying like, no, I actually need to speak to someone. Like I can't just manage this on my own. And due to cost, I haven't continued it, and because it worked really well, I know at some point I'm going to go back when when something stressful comes up again, and know that I have that. If mental health was more accessible, I really would encourage every single person to have therapy all the time. I think we would all benefit hugely from that. It was really helpful to have an outside person. Unfortunately, mental health care is really inaccessible in the US. But if that's something that you need, I think it's one of the strongest things that we can do as people to sort of admit that we need someone else's help.
Definitely. Thank you. The next question is, how do you see the autonomy of the PA profession changing in the future?
So there's a lot of conversations about the PA scope. And it's manifesting in a lot of different ways. The reality is that healthcare has changed so massively in the last 15 years. 15 years ago, there were these private practices. PAs worked with a physician specifically, very similar to actually the way that I practice, whereas the majority of PAs are working in hospitals. They don't necessarily work with a specific physician. And depending on where you're at, you may be legally tied to a physician. So in Pennsylvania, you have a piece of paper that says, I work with this physician, and this physician, and I can do this, this, and that. And I had that when I was there. And in my setting, I fortunately worked with specific people, and then there was other names that were thrown on that piece of paper just in case one of those people was away, or in case, I don't know, whatever came up. And so what really needs to happen is a disconnect between a specific physician relationship and a PA. It works for me. It will always work for me in this practice setting. But for most PAs, they don't have a specific physician they're working for. They're part of a group. And so I don't think that the scope for PAs has to change at all. I think what needs to change is that relationship, what that relationship looks like with a physician, where the PA is just part of the team. They're working within their education, knowledge, and training. They're contributing what they can contribute. And the one thing that changes about the PA scope is, let's say that I had worked in orthopedics and now I'm in my practice and a patient came in and broke a finger. I could legally not put a cast on their hand or put a splint on their hand because I don't work for an orthopedic provider, right? Even if I had that skill, even if I had done it for 100 years, I would not legally be able to do that. And so because of that sort of because of that physician-PA relationship, it actually reduces the PA's scope under what they know and what education they have and what training that they have. So I don't think it's a big change in scope. I think it's just a big change in the way that the PA physician relationship works into something that's much more reasonable for a world that's now all huge hospital systems where PAs are just part of a team.
Thank you so much for your wonderful talk. And for the final question, do you have any last minute advice for pre-PA students and pre-health students just in general?
This is a little bit of like a future advice, and I hope that you'll just take this with you, is it is all about the patients for healthcare providers. It always has been for you. It always should be for you. And there is going to be every single opportunity that you can imagine to take that away from you. And you're going to get caught up in stupid situations, and you're going to get caught up thinking like, I don't want to learn this thing, or I don't care about that test, or I don't care about that exam, or I don't want to stay here and round on patients, or I don't want. But at the end of the day, if you don't learn things, that's a potential risk to a patient, or that's a potential time that you're not going to be able to help someone, or that you might actually harm them, or if you get really caught up in like the politics at work and your relationship with the people you work with, and it's negative, and your patients suffer because of that, that's not helpful. So just always, no matter what you do in whatever healthcare world you end up in, just always think back, why did I do this? It was for the patients, and how do I manifest that in my life in a really positive and helpful way? And you will feel so rewarded when your complete focus is on patients. And anytime that you're not feeling rewarded, I promise you'll realize that you're not focusing on your patients.
Thank you so much. That was amazing. For all of my students, please stick around. At the end, I will go into how to take your post-shadowing assessment. So to start off, I just want to let everybody know that our website was down after our shadowing session yesterday, and this was due to the high volume of students on our website. So what we have to do is raise money. And so I'm asking you all to join our fundraising team by using this QR code. So if everybody could please take out your phone and scan your screen really quickly, it will take you to our GoFundMe page. If you are unable to donate, we all understand you are pre-health students and you may not be financially able at this time. We ask that you share this with your family and close friends, people who are following your social media. Add this as a link to your bio if you're able to. We appreciate any help that we can get. This is part of your health education. We could be charging $1 per shadowing session. However, we don't want to do that because that limits the accessibility for thousands of people around the world. So in order to keep pre-health shadowing free, we just ask that you donate whatever you can, whether it's $1, whether it's $100, and we appreciate anything that you can provide to keep our program afloat. We have a small reflection today, but due to the load on our website, we're going to go ahead and skip this. I invite you to take an image or a picture of this if you would like to participate in this later. This is a great opportunity for you to take a moment and think about what was said during this presentation, what resonated with you, what did you learn, what inspired you or motivated you to even be here today, because those are just really important things to think about as you go into the health field and you achieve your goals and apply to your future programs. Have an announcement for you all. We are taking applications to join our student team. This is a 100% remote opportunity. You have lots of different tasks that you can be working on, so you get well-rounded skill sets that you can take with you to your next endeavor. It looks really great on CVs, resumes, applications. You can meet with like-minded students and gain all types of experience. If for any reason you are too busy or you have a lot going on right now, we totally understand, which is why we have volunteer opportunities, which allow you to help out pre-health shadowing from wherever you are at whatever time you'd like. whatever works with your schedule. And so I really encourage you all, if you are looking to help out, we would appreciate any help we can get. For those of you who are sharing the GoFundMe link, you can actually get your verified virtual shadowing volunteer hours with us. So you sign up on our website using this QR code and send us screenshots of your shares, and we will go ahead and validate that for you. Upcoming challenge: follow us on Instagram to never miss a session. We have a challenge for you today. Comment Jonathan Baker's last name, letter by letter, in our comments for his post, and you will have the opportunity to become the student of the session. Good luck. This is actually really challenging. So good luck with that. Tag us in your posts at Pre-Health Shadowing on TikTok and Instagram. We also have a Twitter and Facebook if you are active on those socials as well. You can get reposted on our official account by doing so. Please just share with everybody. We want to ensure that pre-health shadowing is made accessible to every pre-health student in the world, essentially. And so just giving students opportunity to join our program, whether they do so or not, it's okay. But just letting them know that this is something that they have the ability to do is super crucial. I did not update this. Our next shadowing session will be next week. So to get your certificate that verifies your shadowing hours, you are going to go to the professionals page. Because our website is down, I recommend waiting at least 1 hour to do so. If it is still down when you try, please try again in 15 minutes after that and just try in intervals. We apologize for the website being down, but unfortunately we cannot upgrade until we get more money. So that should be a good incentive for you guys to help us fundraise, because we are definitely trying to keep this program free. You will have 30 minutes to keep the quiz open. After those 30 minutes, you will have to use your second try. So you have 2 tries to complete this. You must pass with a 70% or higher in order to receive your certificate. Please be sure to click Finish Course after passing the assessment. If you do not click Finish Course, you will not receive your certificate. So just make sure that that button is pressed. If you guys have any questions or concerns regarding the assessment, you can email us at info@prehealthshadowing.com, and we will try to get back to you as soon as we can. Thank you all for joining us today, and this concludes our shadowing session. Hope to see you soon. Thanks, everybody. And thanks, Jonathan.